I couldn't stop coughing. It was exhausting.
There were people all around me, but I couldn't get the words out.
I was fighting for each breath. I felt like I was drowning.
The wheezing made me feel like I was breathing through a straw.
It felt like an elephant on my chest.
When I saw my little girl's lips turn blue, I knew it was an asthma attack.
It was scary.
Painful.
Frightening.
Traumatic.
Asthma and COPD are one of the main causes of death in Malaysia in year of 2018. As a pharmacist, what can we do to help these patients to have better lives? It is our duty and responsibility to be innovative and creating good support system to enhance their quality of life. So, for this week, we will discuss the role of pharmacists in the management of respiratory diseases, particularly on the asthma and COPD patients. To achieve the objective of this week's lecture, as a future pharmacist, it is our responsibility to identify the major problems that are encountered by COPD and asthmatic patients. Besides that, it is our responsibility to use the assessment tool that can identify the main factors that cause exacerbations. Besides that, medication reconciliation are important, which are the main way to handle and minimizing the acute or chronic exacerbations. Medication adherence and right technique should be emphasized beside the self-management program. Let's start with the major problems in asthma and COPD patients. The main major problem in asthma and COPD is the poor disease outcome. Not compliance on medication, wrong inhaler technique, and suboptimal effects of the medications are the factors that contributed to the poor disease outcome. Polypharmacy is common among patients with COPD which receiving more than 5 medications. Additionally, hospitalization for an acute exacerbation of COPD is associated with greater disease severity and an increased risk of adverse drug events. We as a pharmacist play a significant role in preventing adverse drug events by critically analyzing the medication list and recommending discontinuation of medications that do not provide effective disease control or drugs that result in adverse drug events. Traditionally, pharmacists play a role as dispensing medication. Nowadays, huge changes have occurred. We as a pharmacist contribute greatly to disease prevention and follow-up of chronic patients to more patient-oriented approach. Respiratory medication therapy adherence clinic, or also known as RMTech, is similar as the MTech that we discussed in last semester in PHC502. This RMTech serves as an ambulatory care service conducted by pharmacists in collaboration with physicians and other healthcare providers with the aim of helping patients in managing their asthma and COPD. This RMTech management includes assessment, personalized pharmacotherapy selection, and ongoing patient education to optimize inhaler use and adherence. Pharmacists play an important role in managing drug therapy and are integral members of healthcare professional teams. Asthma and COPD management should be aimed at achieving good asthma symptom control and minimizing future risk of exacerbations. These goals should be communicated with the patients and carers throughout the treatment process. Patients or carers should be informed of the potential side effects of asthma medications use. When a drug is prescribed, patient preference, the ability of using the inhaler correctly, and cost of medication should all be taken into consideration. The partnership between the patient, carers, and the healthcare providers is important in ensuring the success of the management. Asthma patients should be regularly followed up to assess asthma control and adjust treatment accordingly. The following factors should be monitored and recorded during follow-up. The first, the assessment of asthma control and the numbers of asthma attacks. Second, frequency of bronchodilator use and the use of oral corticosteroids. Third, inhaler technique and adherence. Fourth, lung function assessment by spirometry or PEF, and the use of self-management plan or personal action plan. Here is the video on how to use the peak flow meter. We should encourage and educate COPD and asthmatic patients to use this device to monitor their health status.
A peak flow meter measures how fast and hard you can blow the air out of your lungs. Before each use, make sure the sliding marker is at the bottom of the numbered scale. Stand or sit up straight with your chin slightly lifted and look straight ahead. Keep this position for the entire time. Blow out and empty your lungs as much as possible. Breathe in deeply to completely fill your lungs with air. Put the mouthpiece between your teeth and close your lips tightly. Do not put your tongue on the mouthpiece. Blow out as hard and fast as you can through the mouthpiece. The sliding marker will move up the scale. Look at the number on the meter to see where the marker stopped. Repeat the steps and measure your peak flow 3 times. Record the highest number you reached. Be sure to reset the meter to 0 before each time that you blow into the meter. Keep a record of your peak flow number around the same time each day for 2 weeks while you are feeling well. The highest number is called your personal best peak flow. Your asthma action plan will use your peak flow numbers and give instructions on how to treat your asthma based on your symptoms and peak flows.
Peak expiratory flow, or PEF, measurement may be performed in either a sitting or standing position. PEF is the best of 3 forced expiratory blows from maximum inhalation. Patients are need to record the morning batch 3 PEF measurement and the evening batch 3 PEF measurement. The PEF variability over 2 weeks is calculated by taking the highest PEF minus the lowest PEF divided by the average PEF over the 2 weeks multiplied by 100. A variability of more than 20% is uncontrolled asthma and COPD. We, as a pharmacist, need to counsel and educate patient or caregiver on their expected peak expiratory flow rate as the pictures shown here, so that they can monitor their treatment progress, lung function, and the most important is to avoid any acute attack of asthma and COPD. Collaboration between pharmacists and physicians offers a feasible approach for performing spirometry and can help avoid scheduling spirometry testing to be performed in distant medical facilities. Additionally, pharmacists could enroll office spirometry certification program to enable them to perform spirometry accurately. Pharmacists can play a big role examining COPD and asthmatic patients using a questionnaire, peak expiratory flow, and spirometry testing. In short, it is obvious that pharmacists can help encounter underdiagnosis of asthma and COPD by asking the past medical and medication history, taking into account the history of exacerbations. We can also use the CAT, ACT, or asthma symptom control questionnaire to the asthmatic patients, or using CAT or RMRC dyspnea scale on COPD patients. Here is the list of items that should be recorded in the past medical history. Asthma and COPD patients should stop smoking immediately once being diagnosed. The exacerbation history should take into account when assessing the signs and symptoms. Patients can be categorized uncontrolled asthma, when used short-acting bronchodilator, or also known as SABA, more than one canister in 1 month, or having more than one severe exacerbation in last 12 months. Here is the questionnaire for asthma control test or ACT test. It can be used to the patient that more than 12 years old. Patient can be categorized stable when the score is more than 20. And here is the questionnaire asthma control test for childhood, or also known as CACT. For asthmatic patients that less than 5 years old, we can use asthma symptom control questionnaire to assess them. For COPD patients, we can use COPD assessment test, or also known as CAT. Besides that, modified MRC or MMRC dyspnea scale is another assessment tool that can be used in the COPD patient.